Welcome, everybody, to the webinar, Return to Surgery with Confidence, PPE and the OR team. Today, I will be presenting as well as Jenna Lindsay. My name is Kim Prinsen, and we're very excited to go over this topic with you. We have a few objectives that we'd like to review quickly. We're going to talk about PPE considerations and the challenges that you have right now during the COVID-19 environment. We'll talk about aerosol generating procedures and their impact in surgery. We're also going to look at the different respiratory protection and eye protection options and go through some scenarios that we've gotten a lot of questions on. And we're going to be reviewing proper donning and doffing techniques for the PPE, and also describe some skin safety issues that can be addressed in relation to PPE use. This presentation is based on current United States federal requirements as of June 2020. The U.S. state or other county requirements may be different. Always consult user instructions and follow the local and law regulations related to respiratory protection. So while the focus today is around PPE and the OR teams, I just want to take a minute and acknowledge the extreme challenges that all healthcare providers and teams are experiencing right now. The practice of healthcare is very much guided by evidence-based practice, protocols, and information that's really founded in research and science, and also historical knowledge. However, today we find ourselves living through a very new healthcare crisis that's impacting not only our healthcare systems and how we traditionally have provided care to our patients, but also the lives of every individual globally. And so it's important to really recognize that the work and work practices are very fluid. We're really all quite learning literally as we go, and information is coming at us through all different means. And so that means that there's a lot of challenges and changes that we're facing as we take care of our patients. A longtime colleague of mine and I were talking about her work. She's a surgical services manager, and she said communication is among one of the greatest challenges with her OR team. Initially, just getting her team the information they needed to practice safely and efficiently. And she said in the early stages of the pandemic, they were performing just their surgical or urgent and emergent procedures that they were literally facing daily and sometimes hourly changes in relation to practice. And so that really was a huge concern and frustration at times for staff. And it continues to be a challenge as people move back into surgery. Some people were deployed to different departments, and they kind of have to get back into the swing of their department. And they also are experiencing a lot of changes in practices and protocols. And so we know that this will continue to happen because we've seen states that have gone back to elective procedures having to back off because of surges. And so I think the key thing here is just the importance of communication through all of the work that we're doing and making sure that we're staying informed. So our goal today is really to provide you and your OR team information related to PPE protection so that you can feel adequately protected in surgery. I think if our OR teams feel safe, they can stay focused on keeping the patient safe, integrating new work processes, and adjusting at a different cadence as the situation really requires. What we're seeing consistently throughout the surgical setting is a collaborative approach to planning for and performing surgical procedures in the COVID-19 era. Direction is provided from multifunctional COVID response teams in the IDN or hospital level, as well as departmental and multifunctional teams that address care specific in the area to that area. So, for example, there's certainly a COVID response team specifically focused on the surgical environment. There is probably one in the ICU as well. So we see that there's a kind of an overarching team typically in hospitals, and then more departmental level. And there's a wealth of information to pull from to really help you make decisions that best serve your specific geographical region and patient population. We have guidance from global level, the WHO, the CDC, NICE, federal agencies, the FDA, the NIOSH, professional organizations as well. And we're really looking at the emerging best practices and scientific evidence that's coming out of the work that everybody's doing and compiling together. One thing I love to see is when I go look for journal articles or when I'm looking at different sites, things are now being made available to everybody so that rather than having to have access to specific sites or pay for access, anything related to COVID-19 is really accessible to everybody, because we want to make sure that everybody can benefit from the information that people are gaining in their specific areas. So I think that we're aware that the initial action taken in most locations was to cancel all but emergent or urgent procedures. And that pause really gave us time to focus on the immediate needs of the most critical patients and the staff caring for them. I imagine at this point many of you are very familiar with the joint statement, a roadmap for resuming elective surgery after COVID-19 pandemic. And this is a joint statement that's put together by the American College of Surgeons, the American Society of Anesthesiologists, the Association of Perioperative Nurses, Registered Nurses, and the American Hospital Association. And they really have used this measured approach to pause and prepare, and then learning from those impacted at the earliest stages, and they were able to put together a roadmap that has been utilized by many. And what I will tell you about this particular site, there's a link to it at the bottom of this page, is that they keep your eye on it, because they continue to update it as new information becomes available or new issues arise. So in this particular statement, there are 5 different considerations: the timing of reopening of elective surgeries, what makes most sense in your area based on your level of COVID procedures, and certainly, as I just mentioned, that can ebb and flow, and we've seen surgery departments that have opened up and backed off again because of a surge in cases. They also give us a lot of guidance around COVID-19 testing within the facility, what you need to do before you bring a patient in, what testing you do your staff as well. Personal protective equipment, and that's really what our focus is going to be on today. Also, case prioritization and scheduling, and some different alternate places to do your procedures. For example, if you have your elective cases for a healthy population, would it be best to move them to a site that has no COVID patients housed, for example, an ambulatory surgery center? And then post-COVID-19 issues in the 5 phases of surgical care, and that's really, in pre-op, pre-admission, immediate pre-op, intra-op, post-op, and then post-op discharge. So what issues arise there? There's collection and management of data. That's really important, and that's really, when we collect that data and share it, that's when we all learn and benefit from it. And of course, COVID-related safety issues that are mitigated, ways that we can mitigate risk surrounding the second wave. And that's kind of, some areas are using that information right now because they're experiencing that second wave. And then additional related issues in terms of facility, other facility departments that are impacted, staff issues that arise. So all these sorts of things are really laid out in this COVID roadmap for resuming elective surgery. And as I said today, then we're going to really focus now on the PPE and equipment. So when we look at personal protective equipment, I really want to emphasize that the guidance states that facilities should not resume elective surgical procedures until they have adequate PPE and medical supplies appropriate to the number and types of procedures that they perform. That's a critical piece to have in place before you begin. Facility policies for PPE should account for the following: the adequacy of available PPE, and I think that interestingly, it includes supplies required for that second wave as well, but also we should all be tracking what our PPE levels are, and there's a good calculator, burn rate calculator for PPE that find that on the CDC website and in the ARN toolkit. They all kind of link to the same calculator. It's important that our staff is trained on proper use of PPE according to non-crisis level evidence-based standards of care, but then also right now, what do they need to understand about proper wearing of that equipment? And we're going to talk in depth on that in just a little bit. And then policies for conservation of PPE, what the intubation teams need to be doing, and then extended use or reuse of PPE per the CDC and the FDA guidance. So now we're going to talk a little bit about specific PPE supply needs. Because of the COVID-19 issue, the usage has changed dramatically in terms of PPE not only within the OR but throughout the facility. Items that were once used exclusively in the OR are now critical to the safety of staff caring for patients in all areas. For example, prior to COVID-19, the use of the respirator or N95 was not commonplace in the OR. Personally, I was test fitted for one, but it remained in my locker in a brown bag for the majority of my acute care OR work. Now N95 surgical respirators are needed in multiple areas of the hospital. In addition to masks, consider the following supplies. Each one of these plays some type of role in the protection of staff during the care of patients having a surgical procedure. How many of these items do you think, and it's not an exhaustive list, have been impacted by the demand and supply? All of them. All, depending on the location and the access to supplies. And that's why it's one of the critical steps in the roadmap to resuming elective surgeries, to ensure that there's adequate PPE and medical surgical supplies appropriate to the number of types of procedures that are being performed. So what types of surgeries will take the greatest resources? I'm going to turn it over now to Jenna to discuss. Jenna?
Thanks, Kim. Now we're going to take a look at aerosol generating procedures. In order to stay protected, it's important to understand and identify when there's an increased risk for an exposure. An aerosol generating procedure is one of those times it's critical that you protect yourself. The definition of an aerosol generating procedure, or AGP, is any procedure that can produce aerosols of various sizes, including droplet nuclei. Aerosol generating procedures are a concern because aerosol generating procedures can potentially put healthcare personnel at an increased risk for a pathogen exposure and infection. Unfortunately, there's a lack of high-quality studies that examine the risk of transmission of microbes responsible for acute respiratory infections to healthcare workers caring for patients undergoing aerosol-generating procedures. Evaluating which procedures would be considered aerosol-generating procedures, global, regional, and local professional organizations and agencies lack a standardized or all-encompassing list. When thinking about the operating room, the initial AGP that comes to my mind is intubation and extubation, a very common practice, right? Well, other most often referred to aerosol generating procedures include opening suctioning of airways, sputum induction, CPR, non-invasive ventilation such as BiPAP and CPAP, bronchoscopy, a manual ventilation, a nebulizer treatment, or high-flow oxygen delivery. Again, the list that I just referenced is not definitive and a comprehensive list. Unfortunately, as I said before, there isn't sufficient supporting data to create a definitive and comprehensive list. The table on this slide lists a small subset of agencies and professional organizations along the top. An abbreviated list of aerosol-generating procedures are along the left-hand side. The check marks indicate the organization recognizes the procedure as an AGP. The dashes specify the procedure is not listed as an AGP within that organization, and the question mark designates the organization is uncertain if the procedure should be considered an aerosol-generating procedure due to the limited data available. At a quick glance, the procedures involving direct access to the airways, such as intubation, extubation, and bronchoscopy, are widely accepted. But procedures such as non-invasive ventilation, the BiPAP and CPAP, they're recognized by the World Federation of Societies of Anesthesiologists and the Center for Disease Control and Prevention, but it's not mentioned by the American College of Surgeons. The World Health Organization does state BiPAP and CPAP can possibly increase the risk of respiratory pathogen transmission. I do want to reiterate, there are other agencies and organizations out there and more procedures that are potential aerosol generating procedures than what is listed on this slide. This table helps illustrate the lack of standardization out there for aerosol generating procedures. This slide is just the references for the previous slide. The Association of Perioperative Registered Nurses goes on to identify surgical procedures that may generate aerosols. The risk of transmission through blood and body fluids is unknown at this time. ARN does recommend taking precautions, including respiratory protection, when aerosolized blood and body fluids may be present. The list of surgical procedures includes endoscopy procedures, laparoscopy procedures, tracheostomy procedures, thoracic procedures, electrocautery of blood or GI tissue, the use of high-powered equipment such as saws and drills, and the use of intraoperative debridement devices with irrigation, such as the pulsatile lavage. I also want to point out different surgical specialties have guidelines around aerosol generating procedures. One example is the Society of the American Gastrointestinal and Endoscopic Surgeons, also known as SAGES, and the European Associate of Endoscopic Surgery, EAES. They provide recommendations related to surgery in response to the COVID-19 crisis as well. Although agencies and organizations do not have a standardized list of aerosol generating procedures, the recommended PPE during these procedures is the same among every organization. PPE should cover the torso, arms, eyes, nose, and mouth. For eye protection, goggles or disposable face shield that covers the front and sides of the face are mentioned. A long-sleeve single-use gown and gloves are also recommended. The World Health Organization states that the hair covering is optional. A particulate respirator with at least a NIOSH-certified N95, EU FFP2 or equivalent is a minimum level of respiratory protection during aerosol generating procedures. It is important to note the CDC does not recommend healthcare providers wearing decontaminated filtering facepiece respirators when performing or being present for an aerosol generating procedure. This is due to the uncertainties on the impact of the decontamination on the respirator performance. This is an important consideration and ties back to the roadmap for resuming elective surgery. Your facility needs to evaluate if there's an adequate supply of PPE and continuously evaluate that supply. There are other operating room specific recommended practices for aerosol generating procedures. They can include the following. For environmental practices, perform aerosol generating procedures outside of the OR. As I mentioned earlier, intubation and extubation are widely recognized and widely performed aerosol generating procedures for the operating room. But most organizations are recommending performing these procedures outside of the OR in a single room away from other patients. When intubation outside of the OR, though, is not feasible, it is recommended to allow sufficient time for a complete air exchange of the room to occur. Personnel there should be a minute in the surgical suite, so they are well informed of the risk and well as their protective measures. No one should enter or leave the OR after an aerosol generating procedure until a full air exchange of the room has occurred. The CDC has resources for your facility to reference for airborne contaminant removal and ventilation specifications. For cleaning, after the patient has left the room, leave as much time as possible for subsequent patient care. That's to allow time for the removal of airborne infectious contamination, and the length of time really depends on the number of air exchanges per hour in the specific room or space. And, of course, perform routine cleaning and disinfection using an EPA-registered hospital-grade disinfectant. By no means is this an exhaustive list either of recommended practices for aerosol-generating procedures, but overall, when it comes down to aerosol-generating procedures, it is most important to agree on a list and follow proper safety recommendations. This is just a reference for the previous slide as well. Now we're going to move on to respiratory protection options. There are many different respiratory protection options that are available to help healthcare workers. The variety of options differ based on several factors, including materials, testing, and performance characteristics. First, we're going to review at a high level some of the different respiratory protection options that may be available to you. First are standard and procedural masks. These are meant to be single-use, disposable, simple masks that are used to cover a person's nose and mouth. Surgical masks have the same characteristics of the standard procedural mask, but also have an element of fluid resistance. Please note, procedural and surgical masks are not tested and not certified to provide respiratory protection. Filtering facepiece respirators, also known as FFRs, which you may see throughout the presentations, such as N95 respirators, are meant to be single-use, disposable, tighter-fitting masks that provide an increased level of respiratory protection beyond that of the simpler procedure and surgical masks. They too are designed to cover the nose, mouth of the wearer. Then we move on to more complex respiratory protection devices, such as the elastomeric respirator, which is a reusable respirator. They are available in half and full piece configurations, so some offer eye protection. They do require a bit of assembly because the filter component needs to be attached to the mask for it to provide its intended level of respiratory protection. The last type of device we're going to discuss are powered air purifying respirators, also known as PAPRs. Many of you may be familiar with this type of respirator. They too are reusable devices that come in a variety of head and face cover offerings. These also require a bit of assembly before use, including the head or face cover, tube, battery pack, and belt. Now let's take a more in-depth look at some of the differences between these offerings. We will start with fitment. The standard procedural mask, surgical mask, and most PAPRs are loose-fitting, whereas the respirators and reusable respirators are designed to have a tight fit and seal to the face. All of the respiratory protection device types offer varying degrees of protection to the patient from particles expelled by the wearer. The products that are designed to filter against airborne particles with at least 95% efficiency include the respirators, the FFRs, elastomeric, and PAPRs, thus helping to protect the wearer from airborne particles present in the environment. When it comes to working in the OR, only the surgical mask and the surgical N95 respirators can be used in surgical settings where a sterile field needs to be maintained. The elastomeric and PAPR systems should not be used in the OR or over a sterile field due to the venting of the exhaled air directly into the surrounding environment. Some of the respiratory protection options have the ability for parts of the assembly to be cleaned, which is the case for the reusable elastomeric respirators and the PAPRs. Another key differentiator to understand is the difference between surgical and non-surgical standard masks and respirators. Standard masks, the ear loop and/or tie straps, are intended to protect the work environment, including the patients, from particles expelled by the wick, such as saliva and mucus. Surgical masks have the same protective mechanisms as standard and procedural masks, but also have a fluid barrier component. This helps reduce the chance of blood or body fluids from entering the wearer's nose and mouth. A similar comparison can be made when it comes to respirators. All respirator types are intended to help protect the wearer from environmental substances or airborne particles that are present in the work environment. But surgical respirators have the added fluid barrier component in addition to the protection from airborne particles. Now we're going to get a little filter instead of around the edges before it is inhaled. N95s and other particulate respirators are made using a non-woven fibrous filter media to capture the airborne particles. These fibers crisscross to form a web of many layers. These particles get trapped or captured by several different mechanisms as the airstream flows through the layers. Very large particles of the airstream will settle out due to gravity prior to even making it to the respirator. Then some of the other particles get trapped by impaction, which is when large particles run into the fibers and get caught and trapped. And then diffusion is when the smaller particles float around in the fibers until they get caught and trapped. Once a particle is captured on a filter fiber, it will adhere to the fiber due to van der Waals forces, which is the attraction between molecules. Related to wear time, there's no time limit to wearing a 3M respirator. They should be used in during the entire period of potential exposure and can be worn until they are dirty, damaged, or difficult to breathe through. Use of respirators in the United States is governed by the Occupational Safety and Health Administration, also known as OSHA. They have a respiratory protection standard, which is 29 CFR 1910.134, that specifies the requirements for employers assigning respiratory protection to workers, such as fit testing. Respirators in the United States are tested and certified by the U.S. National Institute of Occupational Safety and Health, also known as NIOSH. Testing and certification is based on the respirator's physical and performance characteristics, including filtration efficiency. For an example, the N95 rated respirators have a filtration efficiency of at least 95% against non-oily particles. Surgical masks, on the other hand, are cleared for use as a medical device by the U.S. Food and Drug Administration, or the FDA, or equivalent agencies such as CSA in Canada. So when it comes to surgical N95 respirators, they are both approved by NIOSH as an N95 respirator, but also cleared by the FDA as a surgical mask. Okay. As mentioned earlier in the presentation, another respirator is the reusable elastomeric respirator. They effectively filter airborne biological particles such as viruses and bacteria, similar to the N95 respirators. The half face pieces are designed to fit tightly to the face with a silicone face seal. Therefore, the wearers need to be clean shaven, the same as with disposable respirators. These elastomeric respirators are also available in multiple sizes, and the head straps are adjustable, allowing the wearer to conform the respirator to their face. These types of respirators are made of synthetic or rubber material, permitting them to be repeatedly disinfected, cleaned, and reused. Also, like N95 respirators, these elastomeric respirators also require an annual fit testing. A user should check the seals each time prior to entering a contaminated environment. Moving on to PAPRs, or Power Air Purifying Respirators. These devices are reusable respirators that typically have loose-fitting hoods or helmets, a hose, a battery pack, and belt. These respirators are battery-powered with a blower that pulls air through the attached filters or cartridges. They too are effectively filter airborne biological particles such as viruses and bacteria. Loose-fitting PAPRs do not require fit testing and can be worn by people with some facial hair. Much like other non-surgical masks, respirators and elastomeric respirator PAPRs should not be used in a sterile surgical field. As we mentioned, N95 respirators are the PPE most often used to protect against exposure to infectious agents transmitted via the airborne route, and their effectiveness is highly dependent upon their proper fit and use. To ensure proper fit, we must perform fit testing. As we've described, form-fitting respirators designed to have a snug fit to the face must seal to the wearer's face in order to provide expected protection. Fit testing is required by the United States by OSHA before a user wears a mandatory respirator and must be assessed annually, as well as whenever a different size, style, model, or make of respirator is used, when any facial changes that have occurred that could affect the fit. And OSHA does not require fit testing administrators to be certified. They just need to know how to conduct a test, recognize invalid tests, and properly clean and maintain the equipment. We see here an example of what fit testing looks like. A good fit means a respirator will seal to your skin. A respirator can only work when air passes through the filter. Air will take the path of least resistance. So if the seal isn't there, the air will go around rather than through the respirator, and therefore lessen the protection. When respirators and fit testing supplies are constrained or not available, it may be preferred to use a respirator with similar construction and fit characteristics than providing a non-similar model. Our laboratory testing indicates respirator models with similar construction may be more likely to have a similar fit. OSHA states if a respirator's model is out of stock, employers should consult the manufacturer to see if it recommends a different model that fits similarly to the model used previously by employees. And further, that a good faith effort to comply with respiratory protection standard includes stressing the importance of visual inspection, user seal checks, and proper training as part of an overall respiratory protection program. Important to note that this is OSHA's guidance is limited to the current COVID-19 public health emergency. The reader should stay informed by frequently checking OSHA's webpage for updates. Again, N95 respirators' effectiveness is highly dependent upon proper fit and use. Here we're going to discuss proper donning and doffing, as well as potential strategies for reuse. General instructions to follow regarding donning your N95 respirator. Donning the instructions must be followed each time the respirator is worn. Ensure fit testing has been completed prior to donning, and do not use with facial hair or other conditions that prevent a good seal between the face and the face seal of the respirator. To help maintain a good seal between the face and face seal, all hair, hoods, or other equipment must be kept out of the respirator face seal at all times. To don the FFR, inspect respirator for holes, tears, or damage or soiling to surface straps, the metal nose strip, and nose foam. Get a new respirator if you see it's damaged or soiled. Hold the respirator in the palm of your hand with the straps facing the floor. If using a flat fold respirator, pull open the folds into a cup shape before placing them in the palm of your hand. Place the N95 respirator on your face covering your nose and mouth, and then avoid touching the inside of the respirator. If donning a used disposable respirator, follow the facility infection control policy, and this may include hand hygiene and clean glove donning. Hold the upper strap and pull it behind your head and place it on the back of your head. Pull the bottom strap up and over the top of your head and put it behind your head below your ears. The respirator should be comfortable and snug, but not over-tightened. This could lead to skin irritation and even injury. Use both hands to mold the nose piece to fit snugly against your face and nose. There are two basic methods for performing a user seal check: positive pressure and negative pressure. As long as they're performed according to the user instructions specific to your respirator, both are considered effective tests of the seal by OSHA. Positive pressure means you test the seal by exhaling while covering the respirator on filtering phase respirators or the exhalation valve on certain elastomeric respirators. The face fit is considered satisfactory if a slight positive pressure can be built up on the inside of the face piece without any evidence of outward leakage of the air at the seal. Negative pressure, on the other hand, involves inhaling while covering the respirator on filtering face piece respirators or the filters or cartridges on the elastomeric respirators. If the face piece remains in its slightly collapsed condition and no inward leakage of air is detected, the tightness of the respirator is considered satisfactory. Doffing instructions must be followed each time the respirator is worn as well. Perform hand hygiene and use other applicable PPE as determined by your facility or infection control policy. Contact infection prevention at your facility with any questions regarding PPE. To doff the N95 respirator, pull the bottom strap over your head. While still holding the respirator in position, pull the top strap over the head and remove the respirator. Discard, again, considering your facility's policy on additional PPE, such as the use of gloves to remove the respirator. So what does that storage look like? What specifically should we do to maintain the integrity of our PPE? The CDC discusses reuse and extended use of N95s as a crisis strategy. They have recommended guidance for extended use and limited reuse of N95 filtering facepiece respirators in healthcare settings, and have published new guidelines on decontamination and reuse of filtering facepiece respirators. According to the CDC, research indicates the virus SARS-CoV-2 survives up to 72 hours on a variety of surfaces. Therefore, CDC is recommending a wait and reuse approach before consideration of other decontamination approaches. One strategy to mitigate the transfer of pathogens from the FFR to the wearer during reuse is to issue 5 respirators to each healthcare worker who may care for patients with suspected or confirmed COVID-19. The healthcare worker will wear 1 respirator each day and store it in a breathable paper bag at the end of each shift. The order of FFR use should be repeated with a minimum of 5 days between each FFR use. This will result in each worker requiring a minimum of 5 FFRs, providing that they put on, take off, care for them, and store them properly each day. Healthcare workers should treat the FFRs as though they are still contaminated and follow precautions outlined in CDC's reuse recommendations. If supplies are even more constrained and 5 respirators are not available for each worker who needs them, then FFR decontamination may be necessary.
All right, thanks, Jenna. That was great information. And now we want to talk a little bit about skin safety in relation to the N95 respirator. Excessive moisture at the skin surface is another factor that can really contribute to skin damage when we're wearing masks for extended periods of time, and especially in some of the conditions that we've seen where there's excessive warmth when you're donned in not only your PPE for your eyes and your mask, but also gowns, cover gowns, jumpsuit type things can really increase the moisture of your body temperature. So we know that the increased skin surface temperature can lead to increased relative humidity or increased skin surface wetness. And what we know is that when the skin becomes wet, it changes the structure and barrier functions of the skin. And the epidermis becomes very permeable, and it can result in inflammation. So microclimate is a term described as the interaction of the skin surface temperature, moisture, or that relative humidity, and airflow at the interface between skin and surface. And what we know from pressure injury literature is that that microclimate has a role in pressure injury development, and that in that complex relationship between tissue temperature, skin moisture, and then friction of a mask at the skin surface causing that friction, and then the development of pressure injuries at different levels. So what do we do when we're wearing our masks for those extended periods of time? There are a number of strategies that you can implement to help prevent skin damage. You'll notice that some of these look very similar to the interventions that you use actually when you're taking care of patients to prevent pressure injuries or device-related skin injuries. So first, what you want to do is pick a respirator that fits you comfortably. As you don the respirator, it's really important not to over-tighten it, because that can, and it's very tempting to do that, but that can actually interfere with the seal and potentially increase the risk for your skin to become injured. Next, you want to adjust the headband so that they're in the correct position. You want to make sure that the headband avoids resting on your ears. You want to pay close attention to any discomfort or pain that you have when you're wearing your protective equipment, as that really is a warning sign that there's potential for some skin damage. So as soon as you can get away from the patient care area and remove your PPE and relieve that pressure, that's important to do. The National Pressure Injury Advisory Panel recommends that ideally, at least every 2 hours, you remove any snug or tight-fitting PPE from your face. If it's not possible, at least lift the PPE from your face at regular intervals. And of course, you'll have to follow the facility infection precautions in terms of how you do that, in terms of wearing gloves and where you do it at. And finally, you want to make sure that you protect your skin from increased moisture and friction. When we're talking about that, we need to understand that any dressing or bandage with a profile can raise a respirator off the cheeks and the nose, and that can interfere with the intended seal and exposure reduction. In the guidance document on preventing pressure injury under PPE, the National Pressure Injury Advisory Panel pointed out that there are no available testing or evidence that demonstrates the seal of the respirator is maintained under the dressing or bandages. If you or your healthcare provider feel that you should wear a dressing or bandage over an area of skin injury, the thinnest, most possible low-profile dressing available should be selected. Once the dressing has been applied, a fit test should be performed. I also want to address the use of common skincare products such as petroleum jellies or ointments, AD ointments, and thick creams that sit on the surface of the skin. In addition to interfering with the seal, they can also cause the respirator to slip or slide. The bottom line is, if the product is being recommended for use under your respirator, ask the manufacturer for the data showing that the seal of the respirator is maintained for that particular product. The National Pressure Injury Advisory Panel advises application of a liquid barrier film or skin protectant to help prevent skin damage from friction and moisture. So at 3M, we did some testing, performance testing, to show that both the Cavalon No Sting Barrier Film and Cavalon Advanced Skin Protectant can be used under the 3M 95 respirator without interfering with the seal. There's data, a document that is available for you to use in terms of how to apply the product and then underneath the N95 respirator. So that link will be available after this webinar is completed. So I'd like to go through a few PPE scenarios. We have a respiratory hotline, really, where people can call in, and so we've got some frequently asked questions, and I just wanted to go over those with you right before we wrap up here. Based on some of the questions that we've gotten from clinicians, we've put together a respiratory and eye PPE selection chart for surgical procedures, and this is something that will be available to you through this webinar series, and you'll have a link provided for this. So if it's something of interest to you, it's certainly something that you'll be able to utilize. And so with that, let's get started on some of our PPE scenarios. One of the questions we often get has to do with clinicians that are working with patients that are positive for COVID-19 or under investigation. And they're also in a procedure where there's it's aerosol generating procedure. So their concern is, what do they do if they have to reuse their N95 mask in this situation? So the most important thing to do is make sure that that mask is fully protected. And what we would do is use their surgical N95 respirator and a face shield. And that's an acceptable way to protect that mask. Of course, when you're through with your procedure, you want to make sure that that face shield fully protects that mask and there's no debris or any obvious contamination to the respirator. The second situation is similar in that the patient is COVID positive and you're also using, you're performing a procedure that is aerosol generating, but this time you do not have a surgical N95 respirator. So what is your option now? The best option would be to use a standard N95 respirator. So that means it's not a surgical one, but a standard one. And again, make sure you have that full face shield to protect the mask. So our third scenario has to do with using valved respirators or elastomeric in the OR in the sterile field, scrubbed in the sterile field or in the OR itself. So the short answer to that is it is not recommended. The CDC and OSHA cautions against using respirators with exhalation valves in the surgical setting due to some concerns around exhaled air coming out of the exhalation valve. In addition, the valved respirators or elastomeric respirators, while they provide a high respiratory protection, they have not been evaluated for fluid resistance or cleared by the FDA as a medical device as surgical mask and surgical N95s have been. So the short answer is really no, it's not recommended to use any kind of a valve mask in the OR specific. So the next scenario then is sterile processing personnel wear an N95 respirator when decontaminating surgical instruments that were used on a patient diagnosed with COVID-19. And the Aerosol suggests that an N95 respirator is not needed for decontamination in the decontamination area for protection from these viruses. Because they are susceptible to detergents and disinfectants. So what's important is the suggestion is that you wear your surgical mask, either regular eye protection, a goggle type, or surgical mask and full face shield along with your gowns and your gloves when you're doing your decontamination. So that concludes our webinar today, Returning to Serve with Confidence, PPE and the OR team. Hopefully we've met all our objectives and you've learned some more about different things that you may be able to put into place, different protocols some training around respiratory protection and skin safety. If you have any questions at all, we'd be happy to take those right now. So thank you very much.
All right. Thank you so much, Kim and Jenna, for sharing this important information as operating rooms prepare for surgery again. I'm excited to ask you some questions that have come through from the audience who are tuned in, so I will get right into it. The first one, can you describe the difference in the surgical hoods used in orthopedics with these other devices like PAPRs?
Yeah, this is Jenna. I will go ahead and take that question. That's a really good question, and it's actually a question that gets answered pretty frequently, or gets asked pretty frequently. The orthopedic hoods are surgical helmets, really cover the head and use a fan to circulate air. And they're primarily used to prevent contamination during surgeries, more specifically orthopedic surgeries, and really protect clinicians from splashes, splatters, of those bloodborne pathogens. On the other hand, the powered air purifying respirator, the PAPRs, are respiratory protection devices. These are specifically designed to filter against the airborne particles with at least a 95% efficiency, thus, helping to really protect the wearer from the airborne particles present in the environment. But I do want to always, I want to say that you should always consult with the manufacturer of the products. I did look at a leading manufacturer of the hoods, and it did state that the hood was not cleared as a respiratory protective device. But again, I just want to reiterate, always check with that manufacturer to determine proper use and to see how the hood or the respirator should be worn in conjunction with devices.
Right. Thank you for that. Next question. Did I understand you say that reprocessed N95s should not be used in a surgical setting?
So I will take that question as well. Not necessarily. I don't have a yes or no answer for that. I did say that the decontaminated respirators should not be worn when performing or present for an aerosol generating procedure. And so that can be in the surgical setting, but the CDC just cautions against when performing or present for an aerosol generating procedure. It does not say a blanket statement about surgery as a whole.
All right, thank you so much. The next question, you mentioned the importance of the fit of an N95 respirator. What other considerations should staff be aware of related to PPE?
So I can take that question. This is Kim. And that's a very good question because I think oftentimes we forget about all the things that can impact it. So first and foremost, when you do your fit testing for your N95 respirator, you should be wearing all the PPE that you normally wear during that procedure. So, for example, your head covering should be on. And it's also important to know that if when you're wearing your protective eyewear, those bows should be placed over the straps for the N95 respirator rather than under the straps, because that can impact the actual fit of the respirator itself. So great question. Bottom line is when you fit test, make sure you have the PPE on that you're normally going to wear and understand, what can impact that fit. Thanks.
All right. Next question, can you wear a surgical mask over an N95 respirator?
So I know we've seen that a lot on just on kind of some of the news reports, and you see that when they're in healthcare facilities. But in reality, we should not be placing a mask over the N95 respirator to protect the N95 respirator. If anything, you can wear a face shield, and the reason for that is that it can really impact the fit of that respirator by covering and or altering the filtering face piece respirator valve. And also, once you impact that fit by placing that mask over, then you void the regulatory approval, and that can impact how it functions for you too. So no, don't wear a surgical mask over your N95 respirator. If you want to protect that mask, or if you want to protect the N95, then you should have a face shield on over it.
All right, and we've gotten a couple of questions related to this next one. What are your recommendations for decontamination of the N95 respirators?
Well, I want to first and foremost say, as you're, part of that return to surgery guidance document really tells us that we need to resume surgery only when we have the adequate PPE and medical surgical supplies, right, appropriate for the procedures that we're going to be doing. And so if we're having to decontaminate our respirators, then we need to really think about the reality of having enough or an adequate supply. So that really suggests that our supply is limited. And that being said, if for some reason you are moving ahead and having to do that, then you really need to follow what your facility policy is in conjunction with the manufacturer's guidance in terms of, how to begin with that reprocessing or decontamination practice. And Jenna, can you add anything to that?
Yeah, I will add a little bit. So just so everyone knows, 3M continues to collaborate with several sterilization companies and institutions that are studying ways for hospitals to decontaminate the 3M's N95 filtering face piece respirators in line with the CDC guidance on decontamination and reuse of the FFRs. And when we, the 3M, are working with these external manufacturers of the sterilization and decontamination equipment, 3M relies on the method developer to confirm the germicidal efficacy of the method and to provide information on the potential hazard to the respiratory users. Then in turn, 3M evaluates the effect of the method on the filtration efficiency and integrity of our respiratory protection products. And we do have more information if you would like it. I have a link to a 3M technical bulletin. And Lindsay, if you could tell us how we can share that link, that would be very helpful.
Yes, absolutely. And that document will actually be available during the on-demand session. So if you access your registration link for this session, within the next hour, you'll be able to download that document, or at least click on the link and access the information. There's actually a whole resources area on your screen right now that has other 3M-related downloadable resources and tools for you. So that will be the spot that you can look for this within the next hour. All right. Anything else that you'd like to add for this question?
I don't think so. I don't have anything else.
Okay,
no, I think
great,
I covered
great.
everything I need to.
Okay, we did get a great comment that came in that says, I think this was great practice with the PPE during COVID-19, so thank you for sharing all the information. That is all the questions that have come in from the audience. Thank you, everyone, for sending in your questions. Jenna and Kim, do you have any specific takeaways that you'd like to share with the audience?
I would just like to say that, again, just reiterate that as you navigate through this era, and it's it's going to be here for a while. So be open to learning from one another. I think that you need to continue to kind of check back to sites that's providing information for us as we kind of go through it. Best practices, things that are making sense in terms of protecting obviously our staff and our patients. So just continue to check back, and I think that's kind of my takeaway. Jenna, would you add anything to that?
No, I will reiterate that. It's changing so rapidly what we're learning, and it's so difficult that continue to just learn, continue to follow best practices, and stay safe. And for those, thank you for everything you're doing out there.
All right, wonderful. Jenna and Kim, thank you so much for sharing your expertise today. I do want to say a special thank you to the 3M team. Without their generous sponsorship, we couldn't provide this free education for you. So thank you so much to 3M. Kim and Jenna, Joseph Stoffel and Janet Proust are all subject matter experts on the 3M team. So we're very fortunate to have them as part of this event today. The final session of the day will discuss the future of OR and sterile processing credentialing, which will touch on innovative education options for continuous professional development, changes to current competency measurements, and alternatives to exam-based certification. So certainly take a moment to grab a healthy snack, refill your coffee or your tea, grab some water. Water's really good for you. And join Dr. Jim Stabinsky later today at 3:30 Eastern for the final session of the day. Thanks again to Kim and Jenna, and we will see everyone very shortly.